Every dentist needs to be able to replace missing teeth with implants using a minimally invasive keyhole approach. In this video, you will learn from an internationally recognized leader in the field of conservative dental implantology, who has transformed the lives of thousands of patients and educated hundreds of dentists through his seminars, webinars, and online training programs. Introducing the father of keyhole implant dentistry, Dr. Joseph Shomelian.
Hello and thank you for watching this short clinical video. I hope you will benefit from the conservative solution that I present here for this particular patient's problem, perhaps a problem which you may face within your practice at some point in time.
This is a routine sort of case that we would all encounter within our practices, the very common issue of a single missing tooth, a single missing anterior tooth, and often patients are unhappy about wearing a partial denture or the idea of having a bridge. So let's have a look at how we would attend to this particular case. When assessing the occlusion, you notice that it's a deep bite, and we want to make sure that when placing the implant that we clear that lower incisor area, especially in lateral excursion. The ridge looks nice and wide, and we're going to place a pilot hole in between the two labial and palatal plates and centered between the adjacent teeth. It really would be a shame to cut these teeth down and do a bridge, wouldn't it? And to wear a partial denture is quite an unpleasant thought, considering the fact that it would have to cover so much of the palate. Here's the partial denture that this particular patient was wearing, and as you can see, a lot of acrylic, two clasps, and that single tooth, which of course had to be strengthened due to the deep bite, with a little metal wire strengthener, and no doubt that tooth had broken off many a time. There it is in the patient's mouth, and although it looks quite reasonable, it's certainly not as ideal as what we're about to do for this patient. So in a single visit, we take that denture, remove it, and place an implant in the alveolar bone. Here's the x-ray, the periapical x-ray of the site. There is substantial sort of crestal bone loss, but interestingly enough, once the implant is placed, the bone will regenerate around that area. Here's the pilot hole, as you can see, centered between the adjacent teeth and placed slightly palatally because of the loss of the labial plate. There it is in a close-up view, about 1.1 to 1.6 millimeters in diameter. The implant is placed without a flap, painless, flapless, bloodless. An excellent way to attend to these situations. There it is, it's a fixed type dentium implant. As you can see, it's centered between the adjacent teeth, ready for an impression and a temporary crown. Here's the x-ray of that case. The 12mm dentium fixed head implant has been placed, and as you can see, it has plenty of threads engaging the bone. We found actually that 6mm of bone connection is all you need for these implants to have a stable foundation for integration. There it is in the mouth. You can see that it really does look as though it's going to be a problem in terms of the vertical length of that implant. But when looking at the occlusion, you can see how the position of that implant clears the lower incisors by a mile. There is no risk of excessive force being applied to that implant. The temporary crown is constructed so that it's clear of contact in lateral excursion, and 2 weeks later the permanent crown can be cemented and the case is complete. The contour of the palatal surface needs to be such that it doesn't lap the ridge too much, so that you can engage the brush comfortably at the margin there. Here's the final outcome, final result. Nice gingival contour, it looks as though it's growing out of the gum, and patients can floss up under the ridge lap crown without any difficulty. The occlusal contact needs to be clear so that in lateral excursion there is no excess force being applied to that implant. There it is again in a closed contact situation. The x-ray prior to treatment and upon completion. The crestal deficiency around the threads actually fills with new bone over a period of 6 months. So during our first appointment, which should only take about 30 to 60 minutes, the steps are as follows. Provide your infiltration anesthesia with a little bit of crestal anesthesia as well. Use lap putty to take an imprint of the existing tooth on the partial denture. Create your pilot hole to the appropriate diameter and depth as required by the density of the bone. Type 1 to type 4 bone requires different depths of pilot hole preparation. Insert the implant with using finger drivers, then set to the full depth using a ratchet. Check the occlusal clearance, of course, take final impressions, and select the shade for your permanent crown. Make your temporary crown a cement with temporary cement. Prescribe antibiotics and mild analgesics. Pain is usually of minimal consequence. That afternoon is all they need to cover. The next morning there's no pain at all. During the second appointment, about 2 weeks later, which only needs to be for about 20 minutes, you remove the temporary crown using a spring-loaded crown remover. Of course, you need to check the fit of the permanent crown and the occlusion, adjust as required. Cement with a GIC cement, such as Fuji Plus. Now, with recommended fees, the implant and temporary crown, I recommend you charge between $1,400 and $1,800, and for your permanent crown, just whatever your usual crown fee is. This was a fairly simple case, so in future videos we'll look at some more complex situations. Thank you for watching.
To attend a live seminar conducted by Dr. Joseph Shomelian, please visit www.miniimplantseminars.com.